It's a beautiful day in the gayborhood. A beautiful day to ask a gay doc with Dr. Renzo Corzano of Desert Oasis Healthcare. Hey, Renzo.
Hi, John. How you doing?
I'm doing great. I'm outnumbered by doctors right now. We would like to welcome to Ask a Gay Doc, psychologist Christopher Hawkey.
Thanks for having me.
It's good
And
to
a dear
have you.
friend of mine.
Explain what you do here in the community for mental health.
So I'm the chief clinical officer over at the center, and I just help sort of guide their programs to bring, the needed services to our community.
And of course, this is Suicide Prevention Month, and we wanted to have you on during the month of September to talk about it. And it's something that people don't talk about, even, in families. I know a couple of generations back, there was a suicide in my family. It just wasn't discussed, but we're going to discuss it.
So I'll tell you guys what I'm seeing in clinic. I'm seeing some weird stuff. Like everybody's having this like collective depression over everything that's going on right now. And a lot of my patients, not a lot, but a handful of them are actually endorsing this like passive, like suicidal ideation, like, no plan, no nothing, but they're kind of basically just saying things like, if I didn't wake up today, I'd be okay. And it seems to me that it's getting more common and it's like more constant. Like in 1 week, I'm telling you, I probably hear that complaint about 3 to 4 times. Whereas before it was like maybe 1 or 2 a month. So yeah, things are getting kind of heavy out there.
Yeah. And I think, so there's sort of like the current context of things that are happening that impact us. But then in our community, we're also constantly managing something that I call minority stress, right? So we sort of have that's just weighing on us all the time, sort of like a thing that we're carrying around. So when those two things come together, they really put us at a higher risk of suicide outcomes than heterosexual people. Yeah.
Do you think that there is a trauma associated with being gay that is pretty widespread? Do you think that we're processing trauma?
Yes, 100%. Chris, we talked about this.
I'll clarify. I don't think that there's any trauma with being gay, but I think there's trauma with being gay in a community that centers and prioritizes straight people. That is where a lot of the trauma comes from.
And so what are you hearing at the water cooler when it comes to the mental health of our community? You're plugged in at the center.
We're hearing a lot about the current socio-political environment, and that is showing up in people's thoughts a lot. And they're having difficulties with sort of creating space where they can process that while still having the space to like be a normal human, and just like do normal people stuff.
Yeah, the center's been really awesome when it comes to bringing the community together in our collective crazy and trying to process what's been going on. They've had community conversations and support groups, but you go way further than that in your end of the building. Tell us about what you're offering at the center.
In addition to just doing our standard individual therapy, we also have a whole host of groups, something like 10 groups that are currently going on, and those are all actually free of charge. And so we have things like a bereavement group that's really well received. We've had for a long time running an election anxiety group, which is actually sort of directly targeted some of these anxieties that people are discussing. And one of my things that I'm bringing to the center is this focus on something called DBT, which is dialectical behavioral therapy. And it's a sort of like a cutting edge type of therapy that's specifically designed to help people manage emotions so that they don't end up getting suicidal. So it sort of like fits really well with, the message of this month's suicide prevention awareness.
But Christopher, we already have the tools to manage it. We've got sex, we've got booze, we've got drugs. That's the off-ramp that a lot of people use. And in a lot of ways, I don't blame them. So are you also dealing with substance abuse and addictions, not just to substances, but also sex?
100%. Yeah. And that's like what it is that people learn that those are strategies that they can use to regulate their emotions, right? Like that's the best that they know how to do. And so what we do is we bring them in, and literally one of the first things that we do is we take them through a set of skills. It's called the DBT skills group. We take them through and teach them this really robust set of skills so that they know many other things that they can rely on to regulate their emotions and not have to do those other things, right? Like impulsively.
I used to love Lily Tomlin's Search for Signs of Intelligent Life. Trudy the Bag Lady would say, I use reality as a crutch because I can't handle drugs and alcohol.
Yeah.
And so you're helping people get the tools to use reality as a crutch and not depend on those things that never have a good outcome.
Exactly. And you find when you do that, like people are pretty happy if you give them the skills that they need to be happy.
Yeah. Are these classes like just Monday through Friday, or do you guys do any like weekend sessions?
Right now, just so the DBT skills are specifically on Thursday evenings. I think they're
Okay.
running 6 to 7:30. Don't quote me on that, but it's around then. And so people show up. It's a virtual class. Again, it's free, and we just run them through. We teach them emotion regulation skills, distress tolerance skills, interpersonal effectiveness skills, and mindfulness skills.
When you talk about mindfulness, and you Renzo have heard those sort of passive, just sort of nonchalant references to maybe not wanting to go on living, do we need to set off the alarm bells when we hear any little hint that somebody's giving up?
For me, it's very subtle, right? I always feel like, I don't know, this may be wrong, but if someone's really gonna off themselves, I think there's really kind of like no talk about it most of the time. Is that true?
I think it depends. I think that there's
Ah,
probably like a bimodal distribution of people. There are some that will proceed that route, right? And then there's some who will over communicate about it and then maybe even accidentally end up suiciding. But I think like the take home message, sort of to your initial point, John, was that not talking about or avoiding this stuff is always the wrong course of action. There's never been any research that has indicated that talking about or asking about suicidal thoughts or suicidal plans or anything like that make them worse. But a lot of providers and a lot of people think that if I ask about it, I might cause it to happen or I might make it worse. That's totally, there's no research to indicate that that's true. Quite the contrary. So, like, we actually do want to be, like Renzo does with his patients, having these conversations and saying, hey, are you thinking about this? And if so, like, let's talk about what we can do to help you with that. Like, why is that coming up?
yeah.
Yeah.
I
And well,
always talk about it because you have to figure out like if there's a plan, if there's any kind of, like guns in the homes and just things like that, right? But like I always find that talking about it, it does make the patient feel better in that moment, but it's also I use that and I tell them, hey, you're feeling a little bit better, just like verbalizing all this stuff. Like imagine how you're gonna feel if you're actually talking to a trained therapist about this. And then once that happens, they're actually way happier and getting help. So that's really good.
and the therapy that you have at the center is on a sliding scale, and the hourly for actual one-on-one therapy is really affordable, and it's certainly worth it.
Yeah, many of our groups have no cost associated with them whatsoever. So, like if you go out into the community and you want to do DBT group, we offer it for free here. And then our sliding scale goes between $20 and $150 depending on how much you make. But we also like try to work with people. We try to see people even if they can't pay.
So about what percentage of queer people are at a higher risk of suicide compared to, non-queer people?
Yeah. Let me break that up a little bit. For lesbian, gay, bisexual adults as a whole, they're about 2.5 times more likely than our heterosexual counterparts to attempt suicide. And if you break it down to just gay men and bisexual men, we're about 4 times more likely than our heterosexual counterparts.
What about transgender people?
You read my mind. Yeah. So interesting. The facts suggest that 1 in 4 trans folks has attempted suicide, and every other trans person likely has experienced suicidal ideation. And it's just the more and more sort of stress, minority stress that you face, the more stigma that you face in out in the community, the higher your risk is. I think that probably also is true for people who have multiple marginalized identities. We call that intersectionality, where somebody might both be a racial or ethnic minority and also a member of the LGBTQ community, or may, have HIV and also be part of the LGBTQ community, right? So when we're managing these marginalized statuses, these marginalized identities, that creates higher stress for us and higher risk.
And what can you do about it medically? Is a pharmaceutical going to fix it?
Personally, I always recommend therapy. And then on top of that, if we need something, or if it's severe depression, then we add, an antidepressant. It also depends for me on like the history of the patient, family history, and a lot of other stuff. But I mean, I'm a firm believer that therapy is, it's gold. I think once you find a right therapist, I think, everything just seems to settle down a little bit. I always try to push for therapy with, a medication, but it really kind of depends on the history too.
Yeah, I agree with that as well. There's certain cases where folks need to be stabilized on medication, and then they can benefit more from therapy. And then there's other folks who actually, like we say, skills not pills for some of these folks because they actually benefit more from starting with the skills side of things.
100%.
Skills, not pills. I love
love
it.
that. That's it.
Thanks again, Chris, for being on Ask a Gay Doc. If anyone has a question for Dr. Renzo Corzano or any of the experts that we bring on, you can send it via email. It's confidential. You send it to lgbtqhealth@mydohc.com. And Ask a Gay Doc is a service of KGay 1065 and 92.1.
And Desert Oasis Healthcare, your health, your life, our passion.
It's even embroidered on his scrubs. Thanks, Renzo. Appreciate you.
Thank you, John. I appreciate it. Thank you, man.
Hey, it's John Taylor. Thanks for watching our video. And don't forget to like and subscribe to our KGay channel so you won't miss anything going on in the gayborhood. And you can always listen live to kgaypalmsprings.com.